Can everyone mute themselves because there is still the
Yeah.
child in the background?
Jesh, can we mute everyone except the faculty? Okay, I think.
Yeah,
So
Amol.
as of now, I cannot do it.
Okay, we are live now.
because I
We
am
can
not
go
the host.
ahead.
Yeah.
So can you please make me the host so that I can at least change the settings as of now for muting?
Yeah, we are live now. We will be starting. Yeah.
Let's start with the welcome now.
Yeah. Yeah. Good evening, everyone. We all are here for the spine symposium and spine webinar today. This is the Pune Orthopedic Society and Pune Association of Spine Surgeons Association affiliated to this Ortho Connect division of Alembic for the educational purpose. And we will be talking about all the revision spine surgery cases today. And we have eminent faculty today from all over the country as well as US, our close colleague, Dr. Alok Sharan, who is practicing in Westmead Medical Center, New York, who's practicing a significant amount of difficult cases, and he's doing a lot of work on awake fusion these days, is our eminent international master. Then we have Dr. Bharat Dave, who is a most eminent person from Ahmedabad. We all know one of the most eminent and prominent personalities which we have from Ahmedabad. He has got extensive experience of spinal surgery and revisions especially. Then we have Dr. Abhay Nene, who is practicing in Wokhad, Bridge Candy and Lilavati Hospital, who is again one of the eminent and prominent figures in the spine circles in India and worldwide, we can say. Then we have Dr. Amol Rege, who is practicing in Pune at Dinanath Mangeshkar Hospital, who is again one of the most prominent personalities and who are in the circle of spine surgery. We have Dr. Suresh Pillai from Calicut, who is practicing as most eminent spine surgeon in Kerala and the southern part of the country, and he has got extensive experience of revision spines. And Dr. Ankur Nanda. We all know Dr. Ankur is in Indian Spine Injury Center in capital city of Delhi, and he is doing extensively great work. And now they have the association of Robot with them, and they are doing excellent advanced technological work. I welcome you all, and I would like to thank the Pune Orthopedic Society, the Pune Association of Spine Surgeons, and the Ortho Connect division of Alembic for this great opportunity. We would like, is Dr. Hardikar is around? Yeah. Amol, we would like to request Dr. Amol Rege to start with his first case. Yeah, Dr. Rege. I think there is some technical issue because Dr. Rege was just online. We will start with Ankur Nanda's cases. We would like Ankur to share his screen and we start the program. Yes, Ankur. And we'll be talking all about revision spine, residual disc, recurrent disc, and all the problems which we face, adjacent segment failure, or any infection in lumbar spine, specifically lumbar spine. Yes, please.
Good evening, everybody. So we are all would like to thank Alembic and Dr. Shailesh to invite me here and be in front of this panel and being able to present a few experience from my side. So we'll straight away start up with the cases. So this is a 63-year-old gentleman who presented to the outpatient department. He had low back pain since the last 3 years. He had a pain which was more of an instability type of pain. He was having difficulty in changing position when getting up from the floor. And as he got up, he used to get that instability sort of pain. He had pain radiating to both the legs, he had this claudication, neurogenic claudication since last 1 year. His walking distance was down to around 500 meters. No major medical illness. He also had a significant bilateral knee osteoarthritis, knee vara was there. But his main complaints were more in terms of neurogenic claudication. Neurologically, he was intact. The power was good. Reflexes were present. S1 reflex was absent. Bowel bladder was continent. And this is how the X-rays looked like on presentation. So we have a straight X-ray AP along with a flexion and extension X-ray here, which we can see. And this is how his MRI looked like. So we got an X-ray and MRI done, and we could see a listhesis at an L4-5 with a big disc which had bulged out on the posterior side. These are the facet cuts from that area. We can see that there's a lot of facet arthrosis at the L4, L5 facet. You can see the facets are full with fluid. There is a big amount of disc prolapse which has come, which is centrally there. And this is the last part of the facet, and you can see it's complete full at both the facets are quite full. So would you like to, would anybody like to take up? What are your first thoughts on this? And is there anything else you are going to investigate?
Actually, the big discussion here would have been, is this an unstable situation or not? Because on the flexion extension, there's no translational or angulatory movement. But on the axial cut of the MRI scan, we must notice that the facet joints are coronally inclined and there's significant facet effusion. So here, if there's no movement in the disc space, it doesn't mean it's not unstable. This is clearly heading for an unstable spine, and this demands decompression as well as fusion. Does anybody in the house have any other thoughts on this? Shailesh, you're muted. Can you unmute and speak?
Yeah. I would like just to check, anyone would like to do any endoscopic decompression or minimally invasive MIS or something like that in this situation? Yes, Amol.
No, not at all. I think I agree with Abhay that it's a very unstable situation. I would do a decompression and fixation.
Yeah, I think the key question is anyone keen on only decompression and not fusing? If anyone feels only decompression will help, can you please speak up?
Wait, can I ask a question?
Yes, please.
Yes, Alok.
I'm sorry, Ankur, I think I missed it. He's had injections, epidural injections?
So we hadn't, to be frank, we didn't give him an epidural injection. And we did try him with conservative treatment initially, which was in the form of, exercises. And we like to use the membrane stabilizing agents like gabapentin, which we use, some anti-inflammatory agents. But to be very frank, we didn't offer him an injection at this point of time.
Yeah, I'm curious, because in America, it's evolving. But, oftentimes before we do a surgery, insurance companies have to approve our surgery. And if the patient does not have bowel and bladder accidents, they want us to try one epidural injection if the patient is neurologically intact before they'll approve payment for the surgery.
Can we get Bharat on this?
Yeah, I would not give epidural injection because it may precipitate cauda equina, and we have had few cases with such a major canal occlusion. Caudal epidural should not be given. Yes, root block may be one of the choice, but I think this is a clear-cut case for surgery. I think we should go ahead with surgery. Let's stop the discussion and go ahead with the surgical, what's been done, and then we have further.
Right, let's go ahead because we are talking of complications. So let's pass the first hurdle first.
Yeah, that's right.
Sure. So just a comment on the injection, and I'll quickly push off. So usually in a situation which is unstable, what we think is that the injection is going to be a very time limiting solution, if at all. So I think we'll not continue the discussion. Anyway, so we thought this was unstable. We thought that there was big compression there. The patient was having significant neurogenic claudication and he was pretty troubled. So, so these were the options. And we decided to go ahead and do a interbody fusion for this patient. And this is what his looked like immediate post-surgery. So we got a good height which we restored. We had a peak cage in place, and this was how it looked immediate post-op. The patient was quite happy, and this was his 6-month X-ray post-op and doing quite well at that point of time.
Does anyone have a problem with this
critical
X-ray?
comments at this, or
Anyone in
should
the
I?
faculty
Can
has
I?
a problem with this X-ray, or everyone's happy with the way it's looking? And does everyone anticipate any problem coming up?
No,
Ankur,
just
can
that
you show the X-ray before this, the slide before this? Ankur, can yeah.
yeah. The only thing is that your rods are
Yeah,
pretty
the-
straight, and then your if you look at the next X-ray, he's flat back. So you've lost sagittal balance there. And the next X-ray.
Right. So what Alok is saying that if you had lordosed him better here, that would have given him because his follow-up X-ray looks like his back is straight. Do you agree, Ankur, with this, or do you think a 2-point fixation does not really need a lordosic rod?
So my
Yes,
thoughts
Dr.
on this are the problem is that this X-ray is not actually a standing X-ray.
Okay.
So to be able to, and these are done, how they are done in the setting. They are taken. The patient is made to lie laterally, and it's impossible to say on the X-rays whether really a flat back has developed or it hasn't developed. So do you all get your post-op X-ray standing in the follow-up?
Yeah.
Typically, most of us do.
Yeah.
Bharat bhai, what do you have to say to this, Dr. Dave?
Yeah, I think at this one level, normally we do not control the road. But yes, if it is one of the choice. But I think right 3-4 facet, it doesn't look normal to me. The upper level.
Yeah. And there is some kind of a rotation and slight translation lateral,
Yeah.
That is what we can see.
Yeah, I
I
think.
think
So
Typically
I'd like to take you to the pre-op X-ray. Can
Yeah,
you see
please.
pre-op X-ray here? You
Pre-op
can see
X-ray?
the
Yes.
yeah. So you can still see the rotation
Same.
here even in the preoperative.
Same. Agree.
Absolutely agreeable.
I think
Right.
to be
So
frank,
Let's go ahead.
that rotation continues to be almost similar in the post-op X-ray, or maybe a little aggravated.
Agree.
But what I can say, what you've done is excellent job day one. That's what I can talk about here, at least for sure.
No comment. Yeah.
Amol, you had something relevant to say?
no, just to be frank to Ankur, seeing this X-ray, I would not expect anything major
Hello.
coming up.
Yeah.
If he's going to show something later.
Right.
So this is his 1-year follow-up, and he was doing quite well at this point of time. As I said, that he had a lot of osteoarthritis, and he came to the hospital for a bilateral knee replacement, looking for a bilateral knee replacement because the knees were restricting him big time. And
Okay.
he was replaced at that point of time, 1 year post-op. And at that time, just before surgery, a check MRI was done to see if everything was okay at the spine level.
Okay.
So this is his X-ray, and I'm just trying to show the L3-4 facets at this point of time at 1 year post-op. So this is how the facet looks like. The MRI looks well decompressed. The alignment is quite nice. And this is how the status of the L3-4 facet was at that point of time. Any apprehensions from anybody at this point of time?
Looks quite okay. Let's see if at all.
What was the reason for doing the MRI?
Yeah, I think the looks pretty okay. I mean, the facet looks not well oriented, but I think that is something which was there pre-operative as well.
So the MRI was done because he was undergoing a TKR, and for that they needed a spinal injection, I'm guessing. So they got an MRI done pre-op.
Absolutely. So the anesthetist wanted to just rule out anything which has developed. He had pain in the legs, and that is why the MRI was done at that point of time.
Yeah, I think as a routine, I mean, a lot of my patients also undergo TKR, but I don't think we get a routine MRI. I don't think that is necessary as a routine practice.
Sure, point well taken.
Was it radicular pain? Was it radicular pain he had before TKR?
No, TKR was typical osteoarthritic pain.
Not any radicular pain.
No radicular pains as such. But
Okay.
I just had this MRI with me, so I thought better show the L3-4 facet at this point of time.
Okay.
Right. Let's go ahead.
Because it will add on to value to what we're going to discuss then. Anyway, so the patient is doing well for another 2 years, and this now we are talking about 3 years later when he comes with episodes of intermittent back pain, which have started in the last 6 months. He has come with a right-sided radiculopathy, increasing pain after walking short distances, and the neurology continues to be normal. And this is what his X-ray looks like at 3 years post-op.
So once again, Amol, if your patient came with an X-ray like this, which clearly shows the adjacent disc now slowly settling, but he has no symptoms, and it's now fourth year post-op, does it even bother you? Do you lose any sleep over this?
If he has no symptoms, I would not bother even getting an MRI, but I will counsel him that he may develop symptoms in future, an MRI and maybe a surgery at a later date. So I'll start counseling him for sure.
Right. Shailesh, do you look at this differently? When you see
No,
a
I think-
radiological adjacent segment, but nothing clinically, do you like to
No,
bring it to the patient's notice, or would...
I would like to just focus on more core strengthening exercises and maybe monitor closely. That's it. Will not think much, Yeah.
Bharat bhai, are you worried about the upper disc or the lower disc?
No, I think both are going to be. I would give probably the LS belt just to remind him that he should not be doing extreme of the activity. Just a corset when he's up and about, not indoor but outdoor at least. That would help.
Right. Does anyone in the house feel that a softer fusion like a PLF or a bone TLIF gives rise to lesser force, on the adjacent discs? Alok, do you have any data on this? A harder fusion like a TLIF causes more accelerated adjacent segment degeneration because of load transfer?
Yeah, so there's some data out there that this is not hard data yet, that MIS TLIF, because you don't take off the posterior tension band, is less likely to lead to adjacent level disease. That's not 100% data, but that's what's being suggested. And then the other data is the interspinous devices, like the Coflex device, for example, is less likely to lead to adjacent level disease. But that's not, I can't tell you 100% yet, but it's trending in that direction.
Okay.
Right.
All right.
Yeah, go ahead, Ankur.
Yes, Ankur.
Okay, so at this point of time, since he had been doing quite well in the post-op period, and he had now started complaining, and I knew this patient quite well. He's not a complaining type of patient. So, I wanted to be more careful. So I went ahead and got a flexion extension done at the same time, just to see what's happening. And I could see there was a lot of angular instability happening at 3-4. As well as there was some movement happening at 5S1, and we could see a vacuum sign creeping up there. We also then went ahead and got an MRI done, and this is what his MRI looked like.
Right. So now there's a clear-cut adjacent level disc that's given way, and he comes with radiculopathy, isn't it, Ankur? Ankur?
Yes. So he's got a right-sided radiculopathy with claudication.
Right. Is it a short duration compelling radiculopathy, or it's just he's just talking about it, but it's not so symptomatic?
So his major complaint was that he's not able to walk up the distance he was walking after the TKR and the first spine surgery. He was doing around 2 kilometers of walking every day, which had now come down to hardly 400 meters or so.
Right. So it doesn't seem disabling, but he seems to be getting there. He seems to be getting on the bad side of things. So in such a situation, again, Shailesh, would you be aggressive and go after this guy, or would you still try to bat around and beat around the bush?
No, there are two things. It's a clear-cut indication, or it can be wait and watch. So this looks like there is definitely instability. There is a large disc. There is pain. This is definitely going towards something which is need to be addressed at the right time. Otherwise, patients will continue to suffer. They will, they will have pain block. They will have some things like that. But it will not give a long-term answer in my hand. So I will definitely consider a surgical option for this case.
Right, Shailesh, we'll come back to you on what surgery you're considering, because I want to ask Amol what his thoughts are. This guy is not completely disabled. He's had one surgery and 2 TKRs. Yes.
Yeah. I think that's exactly the point I was coming to. How much ever you feel that you want to operate on him, the guy has already TKRs and 1 spine surgery. He's going to ask you, doctor, what guarantee can you give me that the next disc will not give a problem after a few years, and again I will end up in surgery? I think that is the most difficult question I face in my practice when I offer them surgery for adjacent disc. So unless he starts demanding surgery, I don't tend to rush really in these cases. if he becomes very symptomatic, he realizes that there is no other choice but to go for surgery. And in that case, that is the time I would offer fusion, extending the fusion to a higher level. But again, I have to counsel him very much well that this above can also give problems and we need to still watch him.
Yes,
Right.
Dr. Dave.
Dr. Dave, we'd
Yeah.
like your input because
think-
there's a specific question that I need you to answer, Dr. Dave.
Yeah.
He's going to ask you that with this surgery, will all my problems end? How will you counsel that?
Yeah, I think I will answer that. But before that, there is disc element as well in this MRI. So the disc is likely to regress. So that he may have symptoms which may settle down. To answer your question, yes, this is going to certainly help you in relieving your pain, and you will have to look after your back in order to, your back looking after you. So that is something which, because that will certainly lead to the progression of the upper level problem as well. But I think sooner or later he will need surgery. If we can buy some time by giving injection, wait for few weeks, maybe if symptoms settle down because of the disc shrink, and I'm sure we can tell him that your symptoms will go. But again, a level above is likely to give you trouble. You are only 63. So, you are going to live for another 40, 50, maybe 20, 30 years. So I think probably we'll end up operating him.
Right. Shailesh, I'm coming back to you because you took the bait and you said that you'll offer him surgery.
Yeah.
This patient has seen Dr. Amol, and Amol says that, I'm not sure if I do another surgery, it'll be the last surgery for you. And hence, if we can manage, let's manage. So he comes to you and asks you, in your hands, will this be the last surgery? Number one, what will you tell him? And number two, will you be worried about the L5S1 disc? Because that's giving way also.
Yeah, definitely yes. Means because when there is a fusion, there is definitely a lot of stress comes on the adjacent segment, either above level or below. This is definitely a concern. But in looking at this X-ray, there is a L3-4 which is toppled up, and there is the disc which is come out. L5S1 also may come in future. We cannot say no. Normally, I tell about 5 to 15% chances that you may need one more surgery in second revisions, because we
So
cannot.
your revision will be only at one level, or will you include L5S1?
I will definitely consider only one level. Better.
Yes, Dr. Bharat. Dr. Bharat.
Yeah, I think L5S1 is settled in
Yeah.
the pelvis, so it will not give trouble. Although it looks bad.
Is the patient really suffering now?
Suresh, he's got a 400-meter walking distance from a 2,000-meter walking
Yeah,
distance.
from two
He's not
kilometers
disabled
now.
yet, but he's heading there.
From 2 kilometers to 400 meters. Now he has problem. He was doing quite good exercise. But if we have to talk to the patient, if he wants to get rid of this, a surgery is an option. But if he wants to continue with the conservative measures, we can do that. But if we do the surgery, I would like to preserve the posterior tension band at L3. So I can do a bilateral flevotomy and discectomy at that area and extend the stabilization up to L3. But I will leave the posterior tension band there.
Okay, what Dr.
Right.
Vignesh? Yeah, Dr. Vignesh. Is Dr. Vignesh online?
Hello, sir. Yes, sir. I
Yeah.
am online. So this is a definite adjacent segment with listus. It's an unstable situation, sir. Dr. Hegde would definitely operate on this. And the disc above that, which is L23, is also a black disc. So he would most probably consider motion preservation at that level, sir.
Okay.
And
so
what about 5-1? The question is 5-1.
5-1 is settled, sir, without any. Well, as
There's a vacuum sign and angular instability. Alok, will you be aggressive enough and go to sacrum?
No. No,
Okay,
because
so I think it's a one-sided. Everyone says they're going to leave S1. There's
Yeah.
one offbeat question. Yes, Amol.
Yeah, the same question I was going to come. Somebody has asked about L3-4 is mainly a discogenic pain. Can we manage it with transforaminal endoscopic discectomy from Dipti Gupta?
So anyone in the house favors any sort of a discectomy, whether it's transforaminal, whether it's interlaminar, just a discectomy.
let's ask Alok. Alok, the man.
Flevotomy and discectomy is also fine, or transforaminal is also fine. Anyway, preserve the posterior ligament complex.
Okay, you will prefer to do only discectomy, Suresh. Yes, Alok.
With the stabilization, I will do stabilization, but I will tried to retain the spinous process and the posterior ligament complex
Okay.
to avoid the same problem in the adjacent level L2-3 above
Got it.
in the future.
Okay. Okay. Yes, Alok.
No, and I think that endoscopic is the best approach because it helps you preserve the posterior tension band, right? So you'll have less disruption. And the problem is not going to be what surgery you choose now. The problem is going to be what are you going to do to prevent any future surgery? And so any surgical choice you pick, you have to basically think, how can I prevent any future surgery? And I think endoscopic would be the best.
Okay. Okay. Yes. What you will do, Dr. Nene?
So just for my clarification, are we talking about endoscopic surgeries without a fixation? Is that so?
Yes. Endoscopic hysterectomy without fixation, I think.
Yes, Dr. Bharat.
Yeah, I think we should be asking the patient the pain, where the pain is. If the back pain is predominant, I think we should fuse it. If the leg pain is predominant, we can very well counsel the patient and do the endoscopic surgery.
I think that's a very good via media. What Dr. Dave is talking about is the pain is most important question. You know, if the patient is with back pain and leg pain, fix him and decompress. If he's got only leg pain, you can get away with decompression. That is.
But I actually strongly disagree here. I strongly feel that we are not treating symptoms. You have to treat the pathology. And this is an instability. I think the option of doing a decompression of a nerve root here is completely outlandish. And there's a pathology there. You just release a nerve root and leave him unstable. He's going to come back again. And he's going to, be your chronic patient. I mean, I'm totally against the idea of a decompression alone.
So you will prefer to fuse it, Abhay. Yeah.
Yeah, I mean, if you're touching him, you got to go the whole hog.
Yeah,
Bharat bhai?
Okay, let's see. I think
If you see, the right-sided L3-4 facet is absolutely opened up.
Yeah.
I mean, if you do a transforaminal here, this facet is very unlikely to settle down.
Let's see, Dr. Dave.
Yeah, I think we have had few cases because the endoscopy is marketed so much at the moment. People just come and demand for endoscopic surgery. Correct. And we have had couple of cases where on demand we did endoscopy, and after a few months they ended up with the second surgery as well after that with the fusion surgery. So what Ankur is saying is right, but then at the same time, if the back pain is predominant, I think we should certainly defer unless even if the patient demands.
Okay. The message is clear. Yes, Ankur, let's know what you did.
Okay.
Please proceed. Yeah.
Okay. So we thought that this was pretty unstable situation, and the L5S1 disc also showed vacuum sign, but we thought that it was pretty settled. So we didn't go ahead and do the L5S1, but we did go ahead and do a 3-4 T-leaf and then and a 5. If you see the CT, the 4-5 is very well fused. So we went ahead and did a 3-4 T-leaf, and this is our 6-month post-op. And if you see the spine still looks flat, and I am worried about the upper level giving way in the coming times.
Well done, Ankur. Well done. So far, he's doing good, and we are happy with the way you tackled this. We can go for your case quickly in 1 minute, rapid fire. The next one.
Sure. So this is another 59-year-old male who came presented with low back pain since the last 2 years. He had again a neurogenic claudication pain relating to both thigh and calf. The walking distance was hardly 100 meters. He had been having this problem since the claudication symptoms at least since 1 year now. He was an avid smoker, smoking since last 30 years. He was neurologically intact, and his bowel bladder was also continent. This was his MRI, and my apologies for the same, but I do not have the preoperative X-rays at this point of time. But this is how the MRI looked like, with a severe L4-5 stenosis, central stenosis, along with a lot of facet arthropathy at L4-5 area. So what we did is we went ahead and we did a one-level fusion L4-5 T-lift, and I thought that I got a reasonably good lordosis at L4-5. The patient was extremely happy immediate post-op, and was doing well at 6 months as well. But at 6 months when he had come, he was complaining of mild numbness on walking, but his claudication distance was quite good. Yeah. What I saw on a routine X-ray was that the cage had started to slip backwards, and it had come down on the right side, on the left side. And he was complaining of numbness. But since the patient did not have much of symptoms, I did speak to the patient about a change in the position of the cage. And I told him that you'll need to be closely followed up. I gave him a brace, asked him to sort of restrict extreme range of motion. and then asked him to follow up in another couple of months.
Here, there's
when
a
it
short
came-
message for everyone that even if you feel that you don't need to treat the slipping of the cage, please make sure that you tell the patient, your own patient, before someone else tells him. Because in today's day and age, it's very difficult to hide your problems under a carpet, and it's better that you tell him, and he's aware that my primary surgeon knows of what's going on. Yes, go ahead, Ankur.
So we followed him up again. So usually after a 6-month follow-up, I would call them at 1 year, but actually I called him again at 9 months. And by this time he had developed back pain also this time, and the left leg pain was increasing. The claudication distance was again coming down. I got the X-ray done again for him, a neutral X-ray, and I saw further shift in the cage. It was coming backwards further. And closely, when I saw the X-ray, the screws had started to loosen out. The L5 screws on both sides, more on the left than the right, but both the screws had loosened out significantly, more on the left. So I discussed with the patient, got an MRI done, and what I could see is that the cage had started pushing on the lateral recess, and you can see here the nerve root on the left side, the left L5 traversing, even though the right nerve root was good, the central canal was good, but the cage was just sitting on the left nerve root. And since patient was having a lot of symptoms, we had already observed him for 3 months, and from between 6 to 9 months period, his symptoms had only increased. Plus the screws had loosened up. So we decided to go ahead and intervene. And what we did was a extension of the fusion to 1 level down. The good part was on the MRI, if you see, the last disc was a rudimentary disc. So there was no problem in coming down 1 level. We had to come down 1 level because the screws had loosened significantly on the left side. And in an attempt to remove the cage, it was a tough job to remove the cage because there was a lot of, I would say, engulfing tissue which had covered the tip of the cage. And while trying to create space, we had to cut part of the pedicle as well. So what we did is we just had a right-sided L5 pedicle and both-sided S1 pedicles. And we did strut grafting. This is a follow-up X-ray, I think around 6, 7, 8 months down the line. And you can see the 4-5 has fused quite nicely. Yeah, so this is what was our final X-ray.
Thank you.
Shailesh.
Well done, Ankur. I must compliment you for doing a wonderful job because, there is always a level above level in lumbar spine. We can see a good anterior fusion occurring at the above level, and nature is giving, automatic stability to the level above. And these are the interesting cases. We would like to go to the next case presentation
So,
with Dr.
Shailesh, just before we go off, I think what we missed was also, this guy was a smoker for 30 years. So I think we must stress on our patients that they need to stop smoking when they undergo fusion surgery, because if they do not fuse, ultimately you're going to have a loss of your fusion and correction.
Absolutely, you said it, Ankur. Yeah, absolutely. That's the important point and message, and we really appreciate your excellent cases. We go to Dr. Rege for the next case. Yes, Amol.
So it's a 72-year-old businessman. He owns a pharmaceutical company. And he initially had leg symptoms for which he underwent endoscopic procedure in 2006. Then he had recurrence few weeks after the procedure, but he still carried on. Then he finally underwent laminectomy in 2008. Then he had back pain and leg pain, so he underwent a surgery till 2010 by a third surgeon. So he had 3 surgeries in a row at almost interval of 2 years. And this was one of the follow-up X-rays which he had when he came to us 3 or 4 years after the third surgery, after the TLIF surgery.
In general, looking at it, what one thing anyone would like to talk about this? Yes, Alok, looking at the X-ray.
The spine is holding the implants. The implants are not holding the spine.
Yes.
Yes, that's most important thing. There are reasons we have to understand biological and mechanical failures, and there's a very clear-cut answer from this X-ray. Thanks. Okay, next, please.
So what he presented to us was actually with severe low back pain. He was in a wheelchair, but he still used to go to his company every day on a wheelchair, transfer to the car and go. And he was on heavy dose of analgesics. And because of that, he had borderline renal failure. His creatinine was 1.8. He was unable to stand. You had to transfer to wheelchair. He had to be literally carried there. And clinically, there was no evidence of any infection. There was no leg symptoms as such, no neurology, no bladder bowel symptoms. He's a diabetic, eats a lot of tobacco, and he's quite obese. And he put on a lot of weight sitting on that wheelchair for a long time. And this was his x-rays when he came to us. And extension views taken in the wheelchair. So moving on to the scans, that is his MRI. Someone would like to comment on the MRI scans? Yes, Ankur.
So I think what has happened is he's gone into a sort of a non-union on the upper area. It's a suit which has formed, possible infection which is there. I like to see some axials as well, but yeah, so I'm looking at some amount of infection as well.
Okay, yes, we can go to the next.
So his hemogram, ESR, CRP was all negative. This was the contrast scans, and that is the CT scan. And you can see that sort of concave convex border at the upper end, especially on the coronal cuts. So what are the treatment options, and how would you like to manage this case? Bharat Bhai, you would like to comment?
Yeah, I think if patient is symptomatic, patient is obese, wants some relief, there is no other way out. I think we should go ahead with the surgery, remove all the old implants, put the new ones, and I think we should really go ahead with surgery. Let's see what you have done, right? I'm sure everybody would agree to that.
Yeah, absolutely, yes.
No, I have a question. Would Alok like to do a back and front surgery here? This is the classic pseudoarthrosis. Infection has been ruled out. So we are fighting biology. So here, would you like to go do an anterior fusion along with the posterior surgery, or would you like to use BMP or anything such?
Yeah, I mean, I think that if you do a good posterior surgery with proper biologics, whatnot, you should be able to get this. My only concern is how much control will you get of the sagittal profile with a posterior approach. That's my only concern. But I would rather do this all posteriorly.
Okay.
All posterior, because patient has got calcified aorta and calcified iliac arteries. You can see it on day 1 X-ray. So that is something which is all posterior only, and we may have to extend the level above as well, because the vertebral body L3 may not hold anything.
Obesity also, yeah. Suresh, anything?
The screws are very loose, broken.
What would be
osteoporotic as well. The spine is severely osteoporotic, and the screws have backed out and broken also. So you have to get additional, along with the removal of the implants, then decompression and additional level of fixation is with the good lordosis would be fine. Maybe you can jack up the level to create good lordosis as well.
Yes, Abhay, Dr. Nene.
Would you like to remove cages?
I beg your pardon?
Would you like to try and take off the cages as well, or just the screws?
No, I was genuinely thinking of a back and front approach because see, I don't have to mobilize the aorta. So calcified aorta doesn't come in my way because I'm going to go lateral. And because it's obesity doesn't come in the way, the fatter the stomach, the farther it retracts itself. So when you do a regular anterior approach, it's like an auto retractor. So I'm thinking of a back and front surgery and go at the cages from the front and put good amount of copious bone graft in the front.
And what about the pseudoarthrosis defect?
Exactly. So to get at that from the front, I'll be able to go. Yeah, with like good corticocancellous bone graft in the front.
Yeah, but I think
do a long posterior, reconstruct posteriorly, and go in the front and fusion.
I think we can do the complete job completely posteriorly, looking at his medical morbidities and obesity.
Yeah, can. I'm just throwing a cat amongst the pigeons and giving another approach. That's all.
There is a lumbar kyphosis also. Take out all the possible implant and prepare a good interbody at the higher level, that pseudoarthrotic level, and good graft at that level. I think.
What do you feel about removing the cages, Shailesh, from the back?
We should try to remove whichever is possible, because most of the time there's not very good fusion is not there. So we just need to check whether they are moving around. If they are moving, we should take the cages out.
Yeah, so they are going to be moving, but very often their path outside to take them out is obstructed. It's very hard to take them out. They are moving, obviously, because it's a pseudo.
If it is difficult to take out, we should add some graft there rather than, playing around too much. That's one.
So do you feel, Bharat, do you feel the cage is an impedance to fusion? If you leave it behind, it's going to come in the way of fusion because now we are dealing with a non-union.
You see, the lower cage was already oblique. Lower cage was not in the proper place either. So if you can remove it, probably yes. But probably yes, it may not hinder the fusion. It won't hinder the fusion. I think we should go ahead, pack the bone graft as Dr. Shailesh said, not without wasting too much of the time. We may not be able to remove it.
Yeah.
Right. Suresh, any quick comments?
Yeah, we can try removing the cages, but if not possible, we can add cancellous graft over there. Create good interbody fusion with jacking up the bone, the graft there. Create a nice lordosis and have additional level of fixation so that the implants will hold till the fusion is solid.
Yeah, perfect. We have a little time constraint. We'll go to the next slide, Amol. Yes. What did you do?
Okay. I'll just show what I did. I basically removed the screws. I did not attempt to remove the cages because it's a nightmare trying to take these cages off. And I extended one level above. And in the pseudoarthrosis, I could get a 17 mm peak cage with grafts. So I need to sort of put it a bit obliquely, but it was very well fixed there. So I could tackle that anterior defect from behind. So I had counseled them that if I'm not able to tackle the anterior defect, I might have to go second stage anterior just to put a bone graft. But fortunately, I was able to do that. And I also extended one level above and one level below. So that's what I did. Any comments on that?
Alok,
I mean, I would agree,
criticism?
I would not get a great sagittal profile.
But still, it is reasonably
Did you-
good, I can say.
Did
Very
you have to do any major osteotomy, or were you able to try? Did you attempt an osteotomy?
Sorry, I could not hear that.
Any osteotomy you did?
Did you do any osteotomy,
No,
or did you try?
no osteotomies. No.
Because it seems like at I think L23 or L34, the bone appeared to be soft. So I wonder if you could have tried just to be a little bit more aggressive with your, like, let's say, bone removal, and then try to, do an osteotomy that way.
You want for the lumbar lordosis more,
Yeah, my concern is the sagittal profile. I think
Alright.
the surgery is great, but my concern is going to be the sagittal profile.
Okay. That.
Yeah, if we go by the book, if you see the pelvic incidence angle here, it seems pretty high and the lordosis seems to be pretty low. So we have not matched it by any standards. But Amol, do you have a longer follow-up on this, like 5 years types?
Yeah, almost more than 5 years. He's
Right.
happy. He's off his analgesics. He's able to walk around, but not much. He's not, but he's happy with what he wanted.
Yeah.
He's off his pain, is mobile indoors.
And there's no PJK radiologically either.
No.
I
But
think
I mean,
you've done a very
the follow-up was only for 2 or 3 years as far as the radiological is concerned.
it was a very challenging case. 3 times previously operated, endoscopic and decompression, open surgery. All the surgeries were done, and it was a challenge where there was an implant which was backed out. And you did a splendid job, Amol. I must compliment. And we can go to the
Shailesh,
next. Yeah. Yes.
just one last comment. Could we
Yes.
consider adding a iliac fixation there?
Yeah,
Sorry?
means definitely that if we think about adding, then why not go up to D10? Okay, then do a complete job. Okay, don't keep any questions answered for a PJK or a DJK. So that's what they talk about. If you want to do it in such situation, go complete.
But
But
that
I
does not
think-
guarantee you anything about that.
But okay, what he has done is an excellent job, and yes, adding SI will not. It will be definitely additional fusion for sure. No question about it.
I think the take-home message is take care of facets and parts during decompression. I think this was probably an iatrogenic problem.
Yes.
Resurgery in spine needs proper planning. You need to think about what approach you're going to take. Identify cause of pain and instability if planning refixation. Start from a normal area to a previously operated area. That is a very important principle for resurgery. And always have a plan B ready. Like in this case, if I could not manage everything from behind, I might need to go anterior.
Perfect, Amol. Excellent. And just rapid fire 1 minute because we are
Right.
really
Yeah.
Can we move to the
Yeah.
rapid fire case?
rapid
Amol?
fire.
Yeah.
Yeah.
The 52-year-old obese lady, claudication distance 250 meters, no neurological deficit. Claudication, she had alpha S1 listhesis and she underwent, it was the MRI scan, and she had undergone this type of surgery at some other center, and the whole level was missed. So now when she presented to us, she was unable to walk more than 10 feet. Her chappals were slipping off, numbness both feet, high stepping gait, grade 3 power, decreased sensations. So this was the MRI scan and this was the CT scan. So any takes as to how would you manage this? Bharat Bhai, you would like to say anything? How are you going to
No, I think
tackle this
carry on.
problem?
Yeah, carry on because time constraint.
Fine. Okay. So we removed the implants. There was a lot of corrosion in there, difficult to find the entry points, and we just revised it to alpha S1 fixation. That's the follow-up CT scan, and she made a significant improvement. Thank you.
Excellent execution, Amol, in a challenging scenario. This is what we want, that the first case to be discussed and second to be rapid fire. We will go to the next case with our international master, Dr. Alok Sharan. He'll be talking about his revision with awake fusion, which is a very uncommon scenario so far in India. And we would like to see what Alok does there. Yes, Alok.
Can I share my screen?
Yes.
Okay, good. Let me just, sorry. Can you see this?
Yeah.
Yes, we can see.
Sorry, okay, so I don't want to take up too much time with the discussion, but I wanted to get you quickly to what we've been doing. You may have heard that we're doing, can you see this now?
Yeah, you can, enlarge the screen, Alok.
Is that better?
Yeah, perfect.
Okay, good. So the case is on the left-hand side. It's a 47-year-old gentleman. He had a herniated disc and had undergone microdiscectomy. He came back to see me 2 years later, and he had this over here. So at L5S1, he re-herniated, he developed degenerative disc disease, he had significant back and leg pain. Okay, so we can debate so many different options. You know, you can do revision discectomy, you could do open TLIF, MIS TLIF, some type of anterior approach. But we chose to do an L5S1 minimally invasive TLIF. Okay, and I don't want to get into the discussion about that. I want to get more into discussion about the awake protocol. So I've been doing minimally invasive surgery for many years now. You know, I used to do a lot of tumors, and so this is a minimally invasive tumor resection. So for me, actually, I've become very facile with doing a lot through the back through minimally invasive approaches. So that's why I like to do that. About 3-4 years ago, we started coming up with this protocol, which we call awake spinal fusion. And I want to be clear that it's a protocol. It requires multiple different steps. It's not just one thing. And what it is primarily we use, now for all of our lumbar cases, we use spinal anesthesia. You can use spinal or epidural, but we use spinal anesthesia. And we do something called a TLIP block, TLIP. And then of course, like talking to the patient, assessing risks. And the goal overall is to get patients out of the hospital faster and get them off of narcotics quickly. So you may be familiar with this TLIP block. That, you know, in like in hip and knee replacements, for example, right? Regional anesthesia is very important. I think regional anesthesia in spine surgery is just emerging. The first paper, this paper I think came out about 3-4 years ago. So this TLIP block is essentially, if you think about the dorsal rami nerve, it comes out and innervates the multifidus and lumbars, right? And so the TLIP block is using an ultrasound. What we do is essentially try to access that interval. And once you access that interval, we deposit medicine into this area. We've deposited lidocaine, marcaine. I use a medicine called Exparel. Exparel basically is a marcaine that lasts for 48 hours. I'm not sure if it's available in India, but I'm sure there are things that you can use that are very similar to it. But we found that you can, if you do it through ultrasound, when you deposit the medicine into this interval, you get this expansion of the space, and the medicine bathes the branches of the dorsal rami nerve. Now, and I'm confident now to tell you that if you do the TLIP block, you're going to be able to get significant pain. We do this before the surgery, right? So we do a TLIP block, and then we do spinal anesthesia. Okay, there's something else called a erector spinae block. At some point, I could tell you about that too. It's very similar, but there's basically two main forms of regional anesthesia. And so using all that now, we have now our protocol. So our protocol is, as I said, spinal anesthesia, not epidural. So we use isobaric spinal anesthesia, a combination of Marcaine and fentanyl, and then you can dose it accordingly. We use the TLIP block. In this situation, we use Exparel, but you can also use Marcaine. And then we do minimally invasive TLIP. So for a lumbar fusion for us, this is our routine protocol. And we've done now 122 awake spinal fusions. So in general now, when a patient comes to me for an awake spinal fusion, my expectation is that they'll go home within 4 hours. Overall, our length of stay is 0.8 days, but generally when I first started, about 30% of patients were going home. Now about 50, 60%, but honestly, about 80, 90% of the patients go home the same day. And then they're off of any kind of pain meds after 1 week. So by combining the spinal anesthesia, which has the fentanyl, along with the TLIP block, we're finding that that a lumbar fusion surgery is not a major surgery anymore. It's a very benign surgery. And this is just some data to show you. We're in the process of publishing this. So basically at this point now, we ask them from 0 to 10 how much pain you have. And then if you look at it, if you follow the protocol, they really don't have much pain in the hospital. And then this is just looking at narcotics. They don't use much narcotics. And then this is just to show you that they're able to go home. And then this is just an example. So this is the gentleman I was talking about. He's 48 years old. And this is him now 4 hours after surgery. This is his x-ray. This is him literally walking, getting ready to go home right afterwards. And this is essentially what we expect now. So we're doing this now in a routine situation where 1 level fusion, hour and a half surgery, and they're able to go home within 4 hours. Okay, so just so you understand, that's the protocol. We indicate this for 1, and we've done some 2-level lumbar fusions. It's critical that the patient can tolerate being prone for about 2 hours. No contraindication to spinal anesthesia. And then many people say that pulmonary disorders would be a problem. I actually think that pulmonary disorders is actually, it's benefit to do it awake than general because of the problems with that. Especially now we know how good prone positioning is for breathing with this whole COVID epidemic. So I would argue that patients with pulmonary disorders would benefit from this. Now I'll tell you this, and then I think this is something that you should think about in India. Why you want to start moving towards awake surgery? 1, you can avoid intubation. And that's going to be a big problem, right? Once the COVID thing slows down, anesthesiologists will try their best to avoid intubation. So if you can do lumbar surgery through spinal and the block, it's going to be a big benefit. And then the other thing is that I'm not sure about India, but I know here in the US that patients don't want to stay in the hospital now. So whatever you can do to get the patients out of the hospital in and out will be good. And we've proven now with awake spine surgery that you can get the patients out. I would argue that if you're going to do awake spine surgery, don't start with spinal fusions. Start doing awake laminectomies, right? 1 or 2 level laminectomies. Just get comfortable with prone positioning, get your OR comfortable. Do about 10 or 20 cases, then move to fusions. Make sure that when you're doing your fusions that you're pretty consistent with your times. Try to get your times down to about 2 hours, and then of course have a consistent team. I wanted to show you this, a couple of things. Let me just show you this. Everyone likes this because during the surgery, a lot of people listen to music. But I have a friend in Italy. I was trying to pull up this. Can you see this video on LinkedIn? Is the video showing up, Shailesh?
It's showing up, but it's not running. If you've not started it, start and
I don't know if I can, but it's not important, but this is my friend Georgios. He's in Rome, in Italy. And so he started doing awake X lifts. So if you go online, you could look it up, but now he's done, I think 4 or 5 awake X lift procedures. So now he's basically, and if you go to his LinkedIn profile, he has videos of people who are up and walking within 4 hours after a single level X lift. And he's doing he does the X lift and he puts in screws while they're on their side. So he's doing a front back surgery awake, essentially, now. And in Rome, it's just been great because he avoids the intubation, right? And they're able to go home the same day. I have another friend who is in Tennessee. I don't have time to show you right now, but I have another friend in Tennessee who does awake endoscopic lumbar fusions. And he follows a similar type of protocols. And now with the endoscopic, he's actually literally doing the surgeries and sending them home within 2 hours. So he does everything endoscopically, cage, screws, everything, and sends them home within 2-3 hours. And it's all based off of this protocol.
Wonderful. We take a quick comment from Dr. Nene and Dr. Dave, sir.
So basically, it's a fantastic concept. Many of us, especially in the Maharashtra Orthopedic Association, have been doing spinal surgery under spinal anesthesia, and they will embrace this concept, quite rapidly. Bharat bhai?
Yeah, I think I was party to my thesis for my MCH in UK, where we used to put the SAN screw with that bird eye view into the pedicle, and we used to patient keep the fixator for 10 days and then let the patient walk and have a feel. I'm talking about 1994, 1995. Anyway, at that time, we had this protocol and we had the bed mattress made specially, and we'll remove these SAN screws and fix the segment afterwards once the patient has got a good relief. And patients really had excellent relief. At that time, the pedicle screw fixation was just evolving. The second thing which we do at our center is with the O-arm and navigation, we can very well do this as well under local anesthesia, where
Right.
things are, pretty smooth and straightforward.
Yeah.
Thank you. I think it was a great.
Yeah, I would say that you can do it under local anesthesia. That's great. You should consider doing the T-lip block as well, because that will give you post-op pain relief.
Yeah.
So then they won't have pain. At this point, honestly, after just a few days after lumbar fusion, they're not taking any much medicine.
Yeah.
So for some reason, the T-lip block, and this is, we have now at some point, if you want, you can contact me. We have a study group, and we're putting together collating data from different centers across the world and across the country. But we're pretty convinced now that the T-lip block and this also erector spinae block makes a big difference, for recovery.
Yeah.
Well done, Alok. I must compliment for doing something, and this is probably going to be a future where people will be going more and more for less and less invasive anesthesia as well as surgery. And
Right.
we really thank you for sharing your thoughts on your work in New York, and really been a great pleasure to be
Thank you.
talking to you. Thanks, Alok. And
No
we go
problem.
to the next case with, can you please, close your screen so that Dr. Bharat Dave sir can share his interesting case.
How do I stop sharing?
You just, there is a icon, yeah. Yeah, Dr. Dave sir will be talking about a very interesting revision, and then will be followed by Dr. Suresh Pillai with his experience. Yes,
Yeah.
sir.
Thank you, the Pune Spine Association and Shailesh and Abhay and everybody for sharing my, this interesting case, which has got a long history. First surgery was done by our best friend, neurosurgeons. She was operated by a neurosurgeon in August 2008. Patient had first surgery, and patient was on clopidogrel anticoagulant. At that time, the symptoms were walking distance 10 minutes, and she was not able to stand more than few minutes, and she was at that time 60 years of the age. These were her pre-operative images before the first surgery, which clearly shows L4, L5 instability. But then still she was not instrumented, and she had the surgery done in the form of decompression. So probably that's what, when she came to us in 2010, April, she was not a happy patient, and she had both lower limb pain, activity of daily living were affected, and she was not able to sleep, and she used to take analgesic every day. But on clinical evaluation, what we found were the upper motor neuron signs and symptoms, they were there. Mainly the signs were there. Hoffman sign, finger drop, clumsiness, and they were all there, but without major neurological deficit. She was power 5/5. And her MRI lumbar spine showed pretty adequate decompression, but don't forget that she was not able to lie supine, and her sleep was disturbed with significant mechanical pain as well, with UMN signs. And That was the MRI, which was showing significant with the X-ray instability from L23, including 4-5 as well. And her C1, C2 was unstable, which was clearly seen on the MRI and X-ray. So here comes the question. This was a tandem stenosis case with the failed back surgery, which should have been instrumented. Should we do both together? Should we do lumbar first and cervical, or cervical first and lumbar? Or should we just do lumbar and do the cervical collar? At our center, we have had quite a few operative procedures done and tandem stenosis surgery. We have published a couple of papers as well. We are quite aggressive and we operate two teams together. And we did in her case, both surgeries together, C1, C2 fusion along with the lumbar fusion, L2 to L5. This remained pretty uneventful. She was okay. She was fine. That was immediate post-op. That is 2010. This is 2 months post-op. She was fine. She had a bit of pain in the thigh, but not that symptomatic. She had that abnormal feeling in the occipital area, which was probably because of the C1, C2 screw. Yeah, and then she went okay. She was a happy patient. Doctor, you have given me second life, but my nerve rotations were restricted. We explained that this is expected with the C1, C2 fusion. She went to Australia at her son's home, and she was all happy and perfectly fine, because you could see that L2 to L5 with the posterolateral bone graft you can see on the gutter as well, mainly seen on the right side gutter. And C1, C2 also was happy going. She came 1 year follow-up. Doctor, now I have pain in both the legs, and that pain is on above knee area, and I cannot stand more than 10 minutes. And I have to take Ultraset twice a day. And here the game starts. I surrender only because of your word, doctor. You have given me life, but now, again, I have the same pain. So we explain as usual, look at your X-ray, they look normal. That is what you can see here as well. And, we said that, okay, we give you belt, and then we carry on with the normal routine activity. ADL improved, and, we said that it was somatization of the pain. And because she had good history, went out. But now look at this 1.3 year follow-up. That was March 2012. She had TKR done. And look at this. That is L23 adjacent level problem. So L12 is getting affected now. And we were worried, is there an infection? Because she had very good relief and low-grade infection that was considered. So here again is the MRI, April 2012. And we were just thinking that should we operate her or should we take the biopsy? But then in just 1 month time, we had aspiration done, which was negative for infection. In just 1 month time, she ended up with this. Do you want to discuss, Abhay, here? Or
Yeah, I think so. No, I think this is not your rapid fire case. So Ankur, this looks like a meal for you. How do you think you're going to tackle this?
So I think this is looking like a osteoporosis along with proximal junctional kyphosis. And the angulation, so we have lost a significant amount of vertebral body. Did she have at this point of time any neurological deterioration, sir?
No, she did not have neurological deficit, but she was in a lot of pain.
She was in
claudication as well as back pain, isn't it?
Yeah, both leg pain and back pain, right. Above knee pain.
Right.
So
any quick tips, Ankur?
So I think what we are going to do here is get an MRI done, see how's the MRI showing. But at the same time, I think we'll need to do something about it. Maybe go ahead and extend the fusion. At the same time, take a biopsy. But I would think this is mainly because of osteoporosis and the PJK has happened because of that. And yeah, I'd like to.
So fundamentally, you won't touch the bottom, and you'll just build an erect tower on top of this. That's what you're trying to say. Yes, would you make an attempt to correct the lordosis and give more lordosis here?
So actually, in the initial time, maybe I would have thought of some interbody fusions to be done. But since it has stood around 3 or 4 years down the line, and if those S1 screws are still holding, although I can see one of these screws seems to be having some lucency, but I'm not sure. But if the S1 screws are holding at this point of time, I'm not going to go do anything at the base of the construct. I think I'm just going to extend it by 2 levels.
Right, Shailesh, what sort of an osteotomy would you prefer if you had to do it? Because she's kyphosing at the top. Would you prefer an osteotomy here to correct her?
Basically, most important is prone down. Most of the times these are not very rigid. They normally open up quite nicely. You don't need to be very aggressive, but maybe you can add up some PCO or Ponte at 1-2 levels. You don't need to be very aggressive in this. They are osteoporotic soft bones, and the minute you position them, you get a good opening. That is one thing which we need to check. But otherwise,
Suresh, does a wedge-shaped bone worry you? Suresh, there's a wedge-shaped bone, and Dr. Shailesh feels that we need not actually close it down.
I should do the MRI and see how it compresses. And if by positioning, if it doesn't get corrected, then I can do a PS pedicle subtraction osteotomy there and then extend the fusion higher up.
Right.
If it is not
Vignesh, what do you feel?
Yeah, Dr. Vignesh, yeah.
Sir, in our center, we would do an anterior corpectomy L1 and stabilization 2 level above in the posterior, sir.
So back and
so
front
decompression from the front.
Right. Because of the wedge-shaped bone. Shailesh, the wedge-shaped bone doesn't worry you. The bone is triangular.
No,
so if you just try to open it up, yeah.
Yeah, perfect. This is not a congenital kind of a deformity, where there is a very like a hemivertebra. This is a soft bone. This is osteoporotic bone. So the minute we position this patient, there is a good chance that this will open up. That is what I personally feel. But
but there will be a big gap left in the front. That's what I was trying to say. It's obviously not a wedge.
Yeah.
And definitely you need to go higher up, and maybe a posterior column osteotomy or Pontes we can do at 1-2 levels. We don't need a very aggressive osteotomy for this.
Right. Yeah. Alok, what would be your solution for this before we go back to Bharat Bhai?
He's not there. He is left.
Okay. So Bharat Bhai, what were you thinking? Did you agree with the rest of the panel who feel just by proning her, you're going to get a lordosis and you're happy with that?
It did open up. It did open up. My question going back to the what is the view of all the panelists? Should we have done 2 together? This is what my question is. About the surgery, both tandem stenosis. Is the practice with you guys doing 2 together?
I think almost all of us work in centers where we have capacity to do 2 together. So mostly all of us do 2 together.
Okay. So what we did was this. We managed to put the bone graft anteriorly. We managed to reduce the bone. And you can see that we have got the good reduction, good lordosis as well. And we have extended 2 level like what Ankur said. And we have put the anterior bone graft. We have put on both the posterolateral gutter as well. And we gave her brace. We certainly started, teriparatide as well. That's what she had. Any comment on this?
Right. Any comments? Suresh, any comments on this? Are you happy with the final result?
Yeah. Yes. Because the wedge of bone you were speaking about that is addressed with the bone graft, so that you don't need to worry about
copious bone graft has been put there and has been addressed.
And also,
Ankur, do you feel you would have done something different here? You're muted, Ankur.
Ankur?
Yeah, go ahead.
I would do the same.
Ankur, you are muted.
So I think I would have done the same. The only difference I may have done is I may have tried to get off the posterior-inferior corner of the body and insert a cage or a strut graft there, because I'm still not a very big fan of cancellous grafting, especially in these situations, because the mechanics are quite in favor of having further kyphosis. So that is the only difference. Otherwise, I've done the same.
Yeah.
Right. Suresh, what was your second plan? You were saying there was a second plan.
Second plan was the osteoporotic. In this case, is the osteoporotic spine. By positioning, if it doesn't come, you can shorten the bone on bone. Through the pedicle, you can shorten the bone so that there won't be, you don't need to graft it anteriorly. Then
right. So like a PSO and shortening and getting the biomechanical axis back. Lovely. Bharat bhai, can you then go ahead and conclude,
Yeah.
or is there more to the
now
story?
no. Story doesn't end here. Story goes on. So she was happy. 2 months post-op, breast given. She was a little bit obese lady as well, and the upper screw has cut through, and the rods are broken now. This is July 2012. She was operated in April. So
Right.
this is July. Just
Right.
in 3 months, 4 months, everything has just started giving way.
So I
The
think what
screw
Ankur
broken.
said, that he's not comfortable using cancellous graft, is almost was prophetic over here. Shailesh, any thoughts on this?
Probably, I think okay, that is the pathology, that is the bone, okay, and I think probably now looking at it, probably I would have stopped at D10, giving when we are revising anyway at a junctional level, 2, probably 3 levels I would have considered that. That's the maximum, but otherwise
But
I would
because the implant has given way, we can't blame the bone actually, isn't it?
That's
the
right.
implant has given way.
That's right. Implant has given way, so the bone quality is not to blame.
Yeah, retrospectively we always feel, but what Dr. Dave had done was an excellent job actually.
Yeah.
Right. Any role of cage plasty? Himanshu wants to know. Cage plasty to reconstruct the anterior column here.
Yeah, I think that's what Ankur said, that you should have done the cage. He would have done the cage, and I think the comment on Dr. Pillai as well, that he would have done the shortening procedure.
Yeah, but cage plasty, Bharat bhai, the doctor here wants to know cage plasty means cement, which I think we should strongly condemn here, because it's an extra-osseous procedure. You'll just have a ball of cement floating there. It's absolutely biomechanically not accepted to do a cage plasty at the level of a disc.
Yeah.
So you can put a cage and put bone graft, but not cage plasty here.
Yeah,
isn't it?
No cage plasty. Sorry, I misunderstood.
Going forward, Bharat bhai.
So what we did now afterwards, we did this. That was anterior cage, and we reconstructed again. We should have gone up to D4, D6. But then if you look at the fusion level, she had already autofusion at the upper dorsal, mid dorsal level. So we stopped there. And we managed to sort of,
we are losing contact with Bharat. Yeah.
Yeah. So that's something which is the end result. She was okay. She had her second knee done as well. And eventually she was in continuous follow-up with us, but then she passed away in 2018, and this is 2014 X-ray. So she went on well. Her husband was a key person who used to come to us regularly, and he himself informed that the patient has passed away, but she was all the time walking around with this 3 or 4 surgeries which we had done. So I would just conclude few things. Aging is inevitable. I think most of us tend to see images. So I think hammer in the hand is very important, very, very important for the tandem stenosis. And now we are dealing with MRSS, multi-regional spinal stenosis. We already are in process of publishing 36 case series where we have done 3-level surgeries, 3 region surgeries in the same sitting with the gadgets which we have. Recognize the problem early, and I think do not procrastinate. I think be aggressive, which is most important, because then it gives us the confidence as well. And I think we have developed that system where we call this as a silver book, where we have this list of patients whom we really need to follow them up. We really need to telephone them. And that's what is the real strength of ours, where we have our reception and the physio. They will work on this and they will keep in touch with the patient. So you do not lose the patient. And most of the time we need to really have the open dialogue with the patient and relative, and we certainly involve them in the decision. Remember that the son was in Australia, and we used to really telephone him, tell him that this is what we are doing, this is what has happened to her. And at the end of the day, we had good result, and she remained mobile till she passed away in 2018. Thank you.
Thank you. Shailesh, take over.
I think it's an excellent case. Dave sir, your was very good, and they are the challenging cases that nothing is in our hand. Whether we could have gone up to D10 or D8, this is not in our. We have to take it as it comes, and excellent execution till the end. I would request Dr. Suresh Pillai to come up with his interesting case, as we are running short of time. Dr. Suresh.
Yes.
Are you around, Suresh?
Can you see? Can you see?
Not yet.
Yes. Can you see now?
You have to share, and there is a right side a blue button. Just you have to share the screen here.
Sharing. Can you see? Can you see now?
No.
Can you?
We can see
Can you see
you,
now?
but not the screen.
Can you see now?
Suresh, have you shared the screen?
Yes. Yes, I have shared. Can you see?
We can't see actually.
Now? Can you see now?
I think you logged out and logged in
Hello?
once, right?
Can you see now?
No, unfortunately not.
No, Suresh, it's not getting sorted.
Hello?
Yeah, we will go with Dr. Vignesh's screen, and then we'll try to get Suresh on. Okay, I will just try to get it. Yeah,
Suresh, try to log off, log on again, and only from one device. You'll probably be able to do it. Until then, we'll finish Vignesh's case.
Yeah.
Yes, sir. 1 minute.
Dr. Vignesh is representing Dr. Sajan Hegde, and the case is presented from that team.
From Apollo Hospital, Chennai. Yes.
Vignesh, come to your first slide and put on slideshow.
Yes. Are you seeing the slides, sir?
Yeah, we are seeing it. Yeah. Yes. Just enlarge the screen. Yeah.
Sir, request you to slideshow. Is it not possible?
Yes.
Yes.
आगे नहीं जा रहा है. Okay.
You can just tap on the Yes.
Okay. So, a 55-year-old gentleman, sir, who presented to us with a history of severe low back pain, which was radiating to left lower limb since 3 weeks. But he had a history of lumbar spine surgery of L4, L5, as well as L5, S1 decompression, which was 1.5 years ago at another center. And in these 3 weeks, he also had got a selective nerve root block on the left side for L4 and right side. That's what the records said. But he did not have any improvement in the pain. And he was able to walk only 100 meters, after which he had to sit for 5 minutes and then again continue to walk for another 100 meters. There was no involvement of bowel and bladder, and the only comorbid condition he had was hypertension. And on examination, his SLR was around 40 degrees, and EHL was 4/5 on the left side. So this was his X-ray and the MRI. So the axial cuts on the right shows both the L4, L5 level as well as L5, S1 and the sagittal cuts.
And the pain block did not help him.
No, pain block did not even help him in 1%. It
Yes,
was same.
what will be your strategy now next? He's operated before, second time now, bad pain, not helping, pain block. What's the next?
Amol, are you there?
Amol is there.
So, yeah, but he's muted and sealed off. So, Ankur, if a pain block does not work at all, does that worry you? At least it should work for some time.
So actually, if the pain block is not working, it's a big problem because, in revision cases, it's very important to look at the source of the pain. So there are only two things which help me in deciding which particular level is getting affected. Either I need to have a solid clinical feedback from the patient that he has to be completely clear of the dermatome, that it's an L5 radicular pain or if an L4 radicular pain. Then I'm still convinced with it. Otherwise, a pain block, even if it gives relief for, let's say, half an hour, is something which really gives you a lot of ease that, okay, if you want to go ahead and intervene, then we are likely to have a reliable result.
Right. So
At the
multiple
same time, we
discs
would
and
also...
you shot one nerve and it didn't work. Bharat bhai, what's the inference for you?
Yeah, I think what Ankur is saying, right? I think we should inject one at a time and see what response they get, and then even plain Sinsorcaine as well, in order to identify if patient is disabled. Then probably, you know, and depending upon the level identified, we should plan the surgery accordingly. I missed the X-ray.
Right.
Do we have the X-ray?
Yes, sir.
Can I please? Yeah. Okay. Oh.
Just a minute.
Vignesh, how did you all proceed when the nerve root didn't work? Nerve root injection, it didn't matter much. Vignesh, what was your thought process when he came to you with no improvement in nerve root?
So, sir, we wanted to see. Just a minute, sir. So this is the X-ray as Dr. Bharat sir asked, and we did not see any significant compression in the MRI. The only thing was that his symptom was more on the left side and weakness was on the left side. So we doubted that the L4-5 level might be at fault. But even we had the lateral recess stenosis at L5-S1 too. So we advised him to undergo a CT myelogram. Now this was his myelogram picture, which clearly showed that there is a lateral recess stenosis as well as foraminal stenosis in L4-5 level with some calcification of the disc. So then, so any comments on this?
So again, Bharat bhai, I'll get you to answer this. There's a significant calcified disc on this, on the symptomatic side. But if you go back to the MRI, there's a disc at L5-1 on the right side, which looks bigger than this one. So what is your approach to this?
Yeah, I think patient has got left-sided symptoms, if I believe.
Yes, sir.
Yeah, so in that case, I think I will go ahead with TLIF, but I will certainly look at the L5-S1 nerve root as well when I am on table. So I think for me, simple as he, probably 4-5 TLIF and 5-S1, we certainly explore and see if there is anything we can tackle it there and then.
Right. Suresh, would you have done a CT myelo in a case like this?
No, usually unless the patient is having a pacemaker or so, I do dynamic X-ray and I don't routinely do the CT myelo. I go ahead with the symptoms, patient's clinical findings, and the MR and the dynamic
Right.
X-rays.
Yeah.
Right. So any reason why you did the CT myelo, Vignesh?
We were not sure about the levels, sir. If we would have just gone with the MRI, then we would have operated on two levels, that is L4-5 as well as L5-S1,
Okay.
and done a 2-level TLIF. So we
Yeah,
wanted
but see,
to
this
be
is
sure.
retrospective. But when you actually asked for it, what was in your mind? Just for the level?
Yes, sir. We in any of these doubtful situations, we usually do CT myelogram.
Fantastic. So that's an important take home from a unit that's been a very high functioning unit, and there's something to learn for us. Go ahead.
Yeah.
Yes, next.
So we clearly saw that there was a compression which was specifically on the left side only at a single level. So so we even found the fragment. It was not totally calcified. So we just we could remove it easily and do a robotic-assisted minimally invasive TLIF. This is the
Right.
post-operative.
Did you look at the left L5 nerve root at all?
No, sir. No, sir.
Right.
As the myelogram was flowing freely at L5-S1, we did not look into it.
Right. Dr. Shailesh, any comments?
Yeah, I think excellent execution and well done job. And they use robot also, that probably is additional safety tool for any such kind of revision. But yes, we can get away with a good TLIF in these situations, I will feel.
Right.
Well done.
Yes, Bharat bhai.
Yeah, I think the cage looks a little bit posterior. Is that what you normally put?
Yes, sir. That would be the our cage.
Is that everybody does the same sort of cage fixation?
You mean it's put posteriorly to get
Yeah.
lordosis? Is that?
No, do we not put a little bit anterior? Because if you
No.
look at the
I think Vignesh said it's put posteriorly to get more lordosis when you compress on it. Is that?
Yes, sir. We do a lot of compression on the side which we have put the cage. That is on the left side in this case.
Okay.
Right.
Okay.
But Bharat, I would agree with you that most of us would be happier if that posterior mark was much more anterior. But once again, Sajan is Sajan and no one questions Superman. Do you?
I agree.
Right.
Yes.
Right. Anything else from you, Vignesh?
No, sir. This case is.
Thank you.
Right. Shailesh, take over.
Excellent execution.
Thank you.
Yeah, just a minute. Just a
And
minute.
one more rapid fire case, sir.
No, just a minute.
Yeah. So put on your rapid fire case. Bharat bhai, you can go ahead.
Yeah, you said you did it in the robotic surgery.
Yes, sir.
So is there any specific thing, which really led you to do the robotic case? Because this was straightforward.
Yes, sir. But it was a minimally invasive. So to do minimally invasive and reduce the radiation exposure, we did the robotic surgery.
The robo has joined Apollo Hospital to learn from Sajan. Let's all understand that.
Thank you. Thank you.
Go ahead, Vignesh. Can you
Yes,
shoot
go
your
ahead.
rapid
Thank you.
fire?
A very short case, sir.
So I think the CT Milo is a good learning point. Most of us ignore it, but the big advantage of CT Milo is you can do dynamic studies on CT Milo. So unlike the MRI, CT Milo can be done with a with a standing. Whenever you do a CT Milo, remember to ask for a plain X-ray also. So once the dye has been put in, ask for a plain X-ray in various positions that you want. Don't miss out on that. Vignesh, go ahead. I'm waiting for you to start up.
Sir, I think there is some problem with this one, sir. I think
no problem. Yeah.
I'll stop sharing as of now.
Close your screen. Yeah. Can you please close your screen, Vignesh?
Yes, sir. Yes, sir.
Close your share so that we can get with Suresh's case. Suresh, are you ready? Pillai, Dr. Pillai. Or should I go with my case by now?
Yeah.
Yeah, I think you should go ahead, Shailesh. We are at 8:30.
Yeah. We'll get when Suresh comes. I'm sharing the screen.
Anyway, somebody is muting it or difficult to share the screen. I'm trying to share it, but it's not coming there.
But Suresh, muting because you're echoing. But if you can share the screen, that's fine.
Yeah, I was. It was muted when I tried to share it.
No, but mute doesn't matter. If you share it, mute doesn't matter. Mute is only for sound.
Yeah. Should I try now? Yes.
You want to try once? Just try. No problem.
Try once. I will just stop my share.
Can you see my?
No, wait. Dr. Shailesh is stopping his share, and I'll tell you when you. Yeah, now go ahead. Share.
You can share your screen now.
Suresh.
Yes, I'm clicking on my share, but it's not coming.
Yeah. No, it's not showing.
Can you do? Sorry. Can you see now?
No, can't. Cannot.
Why it's not coming? Hello.
Did you try to log out and log in again with another computer?
I'll log in again.
Yeah, just try. Until then, we'll go ahead with Shailesh.
Okay.
Shailesh, please go ahead.
Yeah. I am sharing the screen again. Sorry for this little technical hitch. I had kept my cases as a backup for rapid fire in the end last 5-10 minutes, but because of some technical issues, we'll come back with Dr. Suresh Pillai as well. And we have kept some literature from Dr. Himanshu, which he will speak in the last. These are the few cases I'm going to talk about. Interesting cases. 62-year-old gentleman comes with low back pain, right low limb radiation, difficulty in standing and walking, known case of hypertension and obstructive hydronephrosis, diabetic, smoker. Right SLR was restricted to 40, right ankle was weak, and there was no rest. There was quite okay. Only right ankle was weak. And this was his initial presentation, L4-5, all the other comorbidities, chronic smoker, obstructive hydronephropathy, and this was the culprit. And pain was terrible. There was a foraminal component here, and this disc was quite significant compression.
Right. Amol, do you consider this as a stable spine or an unstable spine? Amol?
I would like to see obviously the axial cuts as well as the flexion extension, flexion extension.
Shailesh, do we have flexion extension views?
I think we were having, but
was there any mobility on it?
I kept it as a rapid fire only for therefore.
Yeah, but was there any mobility?
There was no translation, no mobility. Yeah.
No translation. Amol, would you still consider this as stable? Or anybody else, Ankur or Bharat Bhai or Vignesh?
I think it is a stable because you can see the facets, and then there is hypertrophy as well.
Yeah. So, what about the claw sign? That claw sign where the facet claws in is one of the signs of covert instability. Yeah, the hook that you see at the bottom.
Yeah.
Ankur, would you think about fusion here or would you think about decompression here?
So I think the point you brought out is quite well. You can see on the left facet, there is some amount of effusion and there is a osteophyte which is building in. Now the question is, if this patient does have significant back pain still, I would think of talking to him about a fusion surgery. But if the patient is
mainly leg symptoms, mainly leg symptoms, right?
Then even though the claw sign is there, probably it's body is trying to stabilize itself. I'm going to leave it alone.
Right. So just one take-home message, Dr. Ingalalekar keeps telling us about this, that is an uncovered facet. So if you have to do any facetectomy, you got to consider fusion. If you want to do a discectomy alone, you can get away without a fusion. Yes, Shailesh, please go ahead.
Yeah, so we did a decompression, discectomy, and we got a good clearance. We got that disc fragment which was in the foramen, and he was better. He was walking and he was happy. He was back on his medications. There was some kind of abdominal pain in between. He was talking to us, and then we asked the urologist to meet again, and this was 6 weeks. He was doing very fine. Again, he started complaining of pain. He came to us. We gave him some anti-inflammatory as per whatever. And then again, he was having a lot of back pain. The urologist told that we should do the stenting for his ureter and hydronephrosis. We said, okay, go ahead. Now this is a good time because 6 weeks are over, whatever was there. And they did that. There was again pain at the end of 3 months. And again, recurrence of symptoms, back pain. Again, right leg pain was more. If you see here, we can see that there is the stenting was done. His comorbidities were extremely high, and he was with all these things. These are the X-rays we have put. There was not much of a translation at this time also. And
so Suresh, what's your approach? You've done a clean surgery, and there's been post-op back pain and leg pain at the end of 3 months. What's your approach here?
How to evaluate the patient clinically and look back and what you have done, was it correct? Re-evaluation. And if the patient is not, if you can't find something major, then you can try for a trial of conservative. And if the patient doesn't improve, if there is something gross, then you have to evaluate then and there itself. You can do MRI, other examinations.
So now that the MRI is in front of you, what would your approach be? Would you be aggressive about redo surgery here?
Here, I would try a trial of conservative treatment first.
Right. What do you think that red arrow is pointing at? Amol, Bharat, Ankur, anyone? What do you think that red arrow is pointing at?
I think it is a recurrent
disc. 3-month MRI. I'm guessing it's a non-contrast MRI.
And how much is the patient's problem?
Right leg pain severe. Again,
any weakness?
after 2 months started, yeah.
Any weakness? Any weakness?
No, not really. Around 4+ right ankle was which recovered after the first decompression, which came around to 5.
It is routine affected.
Yeah, he was a retired gentleman, and still his pain was quite intolerable at the second time also.
I think we should consider infective versus recurrent disc.
Correct.
Recurrent disc.
Right. Assuming this is a contrast MRI, Shailesh, this is a contrast MRI.
Yeah, this is a contrast MRI, and we always prefer to do
if it's a contrast at 3 months, Amol, if you're able to tell us, this is lighting up, the disc fragment is lighting up. Does that suggest it's a disc, or does that suggest scar tissue? Does it confuse you, or does it give you answers?
There is some scarring which is getting enhanced there, maybe around the disc.
Yeah, probably a disc fragment. One point I would like to make is somebody who comes back with procedure always think of infection first. if he has a urinary intervention. Fortunately, this person not seem to have infection changes at least of the MR. But one that thing you need to keep in mind.
Yeah. As Amol said, is absolutely right. We did the MRI. There was no infection. Some amount of ESR was raised because of the procedure, the ureteric stenting. And we again thought of considering a decompression surgery in this. We went with the decompression, and lucky that he is doing fine now, nearing 1 year. And
you found a disc fragment there?
You found a disc fragment. Yeah. We found a disc fragment there.
Right.
Yeah.
So quick question, Ankur, at 3 months, would you prefer to do a contrast MRI or a plain MRI if you had to do a
Did you
redo MRI?
consider giving a root block?
Ankur, would you do a contrast MR or a plain MRI at 3 months?
At 3 months, I would first do a plain MRI only, not a contrast MRI immediately. Once I feel that there is a doubt, then we can go secondarily for a contrast MRI. But I won't do a straight away contrast MRI at 3 months also. The patient
Right.
comes
Bharat,
with
any
pain. We
difference
like
of
to see-
opinion?
Yeah, I think we should have a good relationship with the radiologist. You have the report same time, same minute, and if they give us the report that this is something which I am looking fishy, then contrast to be injected same time, same minute, so you have the answer immediately ready for the patient to sort of the next plan. So I think the best option will be develop the relationship with the radiologist. We are blessed by that.
There can be a scar tissue also. Sometimes it can mimic, and
it makes
we have
sense.
to
But
be
when you
very
get a
careful.
patient within the first 3 months of the surgery, your first infection, your first doubt, as Dr. Amol was saying, is a low-grade infection. So you're looking for a low-grade infection if it's there. And only once you see that there is nothing else like that, then you go and get the contrast done, maybe at the same sitting like Dr. Bharat said. But first, I would do a plain MR.
Absolutely.
Dr. Gupta from Jaipur is suggesting that on day 1, we should have done a transforaminal endoscopic decompression and not a posterior surgery. Any takers for that?
Yeah, these are the different ways to skin a cat. You can do MIS, you can
Right,
do
sure. Shailesh, you're going ahead with your next case?
Sir, one comment, sir.
And this is
please.
a young
hang on, Shailesh. There's a comment from Vignesh.
Sir, these are the ideal situations where we would like to do the CT myelogram and find out, sir.
In the post-op status?
Yes, sir. Post-op status where it's not clear even in MRI, is it of scar tissue or a disc or whatever it is.
Right.
We would go
I think
for
that message is coming loud and clear that whenever we are at 6s and 7s, the CT myelo is a very underutilized investigation and we must use it. It's very easy to do. And when you ask for it, you also ask for a plain myelo and do flexion extension images. Thank you, Vignesh. Yes, Shailesh.
Yeah. Fire with few interesting cases we have. And this is a young gentleman was operated elsewhere with L45S1 fixation for a lytic listhesis. This was his preoperative MRI, and his pain worsened after the surgery. And the reason was probably the primary surgeon felt that the left screw was breaching, could be some nerve irritation. They reopened and they put the L5 screw on the left side. The patient's pain did not improve. If you see at the listhesis, it was unreduced and the patient was in tossing pain. He came to us at 4 weeks and this is what was his situation. Large disc, and at this minute we gave him a pain block and we sent him back because there were 2 surgeries in a month's time. His pain was really bad. We gave a pain block and we sent him back. He was begging. He came on a stretcher. We said, we'll just see how it goes. And again, in 2-3 weeks time, they came back with similar pain. Pain settled for 2-3 days initially after the pain block in the foramen, and they came back with this. And then we we did a CT scan and everything. We planned for a revision for this and interbody at L5S1. And we were lucky that we got him of complete pain relief. And this is, as I mentioned, that we gave block and sent him back. And this is what was the last picture. And at 6 months, he was doing fine. At 3 months, he was completely pain-free and he was doing fine. What I felt probably at lytic listhesis, interbody fusion is probably a better option than intertransfers. But there are people who are doing intertransfers with good nerve root decompression in lateral recess and they can get away. Here, what I found was there was persistent ligamentum flavum, lateral recess was not decompressed well. When we did a T-leaf, we found these things were there, which were the entrapment of the nerve which was causing the pain. Yes, any
Yes,
comments?
I think that's an important take-home message here, that when you're decompressing a lysis, remember the pseudoarthrosis is the cause of compression and it compresses the exiting nerve root. And if you miss out on that and just do regular laminectomy and foraminotomy, you're going to just get the S1 nerve root and the L5 nerve root will be left undone. And you have to go laterally with your forward and trace the L5 nerve root on the affected or both sides all the way out. If you don't do that, it's not to do with the T-lift as much as it is to do with the decompression. Of course, T-lift will make your construct much more stronger. So generally, most of us on this side of the table accept that for a lytic, an interbody fusion is a far better approach than a posterolateral fusion. Any other comments from the faculty? Else, Shailesh, you can go ahead.
No, we'll go ahead.
We have
I'll
the
go with
last
some
10 minutes of our meeting. Yeah.
rapid fire I will go with now. A few cases. 56-year-old man, 7-year operated L4-5 stabilization with long segment decompression, comes with leg pain, left leg pain, excruciating. He was a policeman, and this is what was his MRI. There was extruded disc, mainly leg pain. He was not with any back pain, and 1.5 months he was suffering with this locally. He was getting treated, and the pain was not settling. When he came to us, we did all the investigations, and we thought of extending the fusion. We kept both the options. This was the first MRI of the first surgery, and we opened posteriorly, and we were lucky to get the large fragment which popped out from the lateral recess, and we cleared both the nerve roots here. We were lucky, and because of only leg symptoms, we decompressed and we came out.
Right. Ankur, do you agree with this plan? Decompression alone for an adjacent segment.
This is the MRI
disc?
and this is.
I think I would agree with it. The only thing is we know that when already a laminectomy has been done and you are going again for a decompression and you're trying to do a fragmentectomy, you may end up sacrificing the facets. So screws is always going to be on my mind, but I'm going to always be ready with T-leaf. But I think if you look at the pre-op scans, there was a huge gap between the dural lateral margin and the facet area. So they had that space to get, they were lucky to get a soft fragment, so they got in early. Yeah. But more often than
anyone
not,
in the faculty would have opted a fusion
actually, because they've already been operated and it's difficult to get through the division area.
Right. Anyone would have opted for a primary fusion here instead of a discectomy? Bharat?
No, I think in our center, probably we may subject him to the endoscopic discectomy. We have extended our indication for endoscopic discectomy up to the cauda equina as well. And that's recently getting published as well. So probably, endoscopy can do a lot of wonder things as well when such revision, where you have already disturbed canal as well.
Yeah.
So yes, and what Ankur said is also right, that, one may keep it as a spine surgeon, the fusion surgeon.
Right.
Okay.
So, but this guy you have a follow-up on him, Shailesh? Like 2-3 years?
Nearly 1 year now, he's managing well, and sometimes he complains of neck pain or something, elbow pain, kind of. Not.
So basically, this dilemma is an unanswered dilemma for the last century, more than a century, that whether a black disc should be fused or should a decompression suffice, and we still don't have the answer. We just learn from our anecdotal experiences. Go ahead, Shailesh.
Again, this is a 65-year-old lady, comes to us, couldn't walk, back pain, leg pain, and this was her X-ray. She was operated for 2 times, lumbar decompression, endoscopic surgery was done, and again after 2 months it was repeated. There was not much of a relief when she came to us, and she was in crippling pain. She couldn't get up and walk, and this was the dilemma. Because of the minimally invasive surgery, we had a lot of different options, whether we should do a formal decompression or we stabilize. She was in sitting, even sitting was painful. In this situation, we planned for a complete job. We planned for a fusion. We did a T-leaf in her case, and this is nearly a year follow-up. She's absolutely fine, managing most of the things what she needs to do for her daily living.
Right, fantastic. Suresh, is your screen going to show up? Do you want to try once with Suresh, Shailesh?
I'm sharing.
No, first Shailesh has to unshare. Shailesh, is that okay? We'll give Suresh a shot.
Yeah, or I'll just finish in 3-4 minutes and then we'll give Suresh, because then again it.
Okay, sure.
Yeah, I'll just quickly finish the cases, just like a rapid fire, and then we'll give it in 4 minutes. Yeah. This is a 65-year-old female comes to us with previous surgery. She was operated with lumbar fusion 4-5 years back, and she had a fall, and there was a L2 wedge compression fracture at a junctional level. And again, it's a dilemma whether we should just do a vertebroplasty, such a big fusion. We thought of keeping all the things with us, and we planned for a long fusion. And we went ahead with a fixation just because of the junctional level, previous 4-level fusion. We wanted to stabilize the spine, and we got away. She's doing fine so far. Again, a 35-year-old computer engineer, back pain, lower limb radiculopathy, operated with minimally invasive surgery 1 year back, double level disc, persistent back and leg pain. We planned for a 2-level fusion surgery as his demands were quite significant. Back and leg pain, both the things were there. We did decompression and stabilization, and we got away, and he's doing fine now. Nearly 2 to 3 year follow-up. He's doing most of the activities of daily living, and overall happy so far. 67-year-old obese male comes to us, twice operated before with buckling, difficulty to stand and walk. This surgery was done elsewhere and out of India actually, and he came to us with this, and we can see there was some amount of motion occurring, lateral deviation at the adjacent segment, and this was a disc which came out at L2-3. Very demanding businessman again, and this was his complaint. He was admitted in other hospital, pain relief was not adequate, and was offered surgery. Again, we planned for an extension of fusion and decompression at this, because only decompression probably would have not sufficed in this junctional level. Dynamic fixation probably would have not given him a good answer, and therefore we planned. We do this in transfacetal approach, lateral, posterolateral approach, and we do the decompression without touching the midline. We go anterior, and we can do a good clearance in such situations. We can do a good interbody cage and grafting. We can see the nerve root, and discectomy was performed, and he is doing very fine so far. And the last case, 62-year-old man, operated again twice before, comes to us. He had weakness in lower limb, in ankle. One ankle was weak, difficulty to walk. If you see, there was a complete lumbar kyphosis. This was his picture. Previous laminectomies twice, and significant disabling pain, low back and low limb pain with sagittal imbalance. We always do a whole spine X-ray in these situations. If you see multi-level discs, and again a problem, this is where we have to think whether we should stop at L2 or we should go above. Normally, we don't like to stop at a junctional level in such kind of lumbar kyphosis, as we have a good experience of lumbar kyphosis deformity and revisions. We planned for a long construct and decompression in this situation. We did all the possible investigations, dynamic X-rays and CT scans, and we planned for this multi-level decompression fusion for this particular case. And this is what we did, an interbody at 2 levels, and we try to get a reasonably good contour for the lumbar spine. And he's got pain, the pain got relieved significantly. His ankle did not improve, but he's walking with stick support, and he's overall very happy. So this was quite a challenging kyphosis of lumbar spine, where we could manage to decompress. We did a double level facetectomy bilaterally so that we could achieve a better sagittal profile in this case. Any comments?
Right. Fantastic, Shailesh. So any comments while Shailesh will unshare his screen, and we'll attempt to launch Suresh once more. Yeah, fantastic result.
And
So, so it was a challenging case, I think, but we'll like to see the long-term follow-up for this. The problem is it's looking pretty straight. So I understand from Shailesh's angle, he has tried to get a kyphosis corrected, but still looking pretty straight. And I think long-term follow-up will be interesting to see here.
Yeah, it's always a challenge to get back that lumbar lordosis of that level that is expected of us by the French people. So thank you, Shailesh. Can you unshare your screen, and can we have Suresh to try and share his screen once? Suresh, just hang on a minute. Let let the screen get unshared. Yeah, go
Yeah,
ahead,
it is
Suresh.
already done.
Suresh,
You see?
no, Dr. Pillai.
Yes. Oh, yeah, yeah. It's coming. Can you?
Yes, okay. Congratulations. Well done.
Finally, so, this one.
Go ahead, Dr. Suresh.
Come. Can you see?
Yeah,
Yes.
we
Can
can
you
see.
see? Yeah.
You need to go to the.
This is a 56-year-old male. He fell from an auto rickshaw and fractured his L3, and he was operated elsewhere with the stabilization one level above and below, and a laminectomy at L3 also. He came to my OPD 70 days after the primary surgery with severe back pain and night pain and continuous throughout the day and night pain. This is the initial X-ray.
Yes. Any thoughts, anyone?
This is MRI. Yeah. This is I did an MRI. This is MRI. So anybody want this? This is MRI. Anybody want to? Hello, can you
Any
hear?
comments on the MRI, that big white ball that you see behind? Is anyone worried, Bharat bhai?
Yeah, I think there could be CSF leak as well, and there is probably the disc. Both discs are affected. I think both the discs, they look bright as well. The vertebral body is collapsed.
Yeah.
I think let him finish, because I think there is one literature review as well, now.
I think we'll
No,
run
no,
out
we
of
will.
time.
Yeah, we will end up with this.
Right.
This is because he had to fall from the neck pain, and so the MRI showed collection behind, and the device also got infected. I think the skull X-ray showed punched out lesions, and ESR was 70 millimeters. Electrophoresis was negative. So I planned it as a revision surgery, and lot of pus, big pus came out, and simultaneously the implants were loose. I removed the implants and took biopsy from L3, and the culture grew MRSA, and the patient was treated with the culture sensitive antibiotic for 6 weeks. After 6 weeks, he came back to the theater again and instrumented 2 level above and below. He was fine after that, and for another 8 months, he was treated further by the medical on chemotherapy, and he was doing all his normal activities. But after 8 months, he presented again. The swelling for the back, and the implants are loose. So went in again, there were a lot of pus. The pus was removed, and the loose implants also were removed. So the implants again out because of MRS infection again. And he was immunocompromised and started on antibiotics again. And this is prone for MRSA. And in this case, initially there was a burst fracture of L3, and without proper evaluation, a laminectomy also was done. So a 180-degree instability was converted to a 360-degree instability and inadequate fixation. Then because of myeloma, he got infected, the implants were removed, then he re-instrumented, put on chemotherapy, his immune status was very, very low. Then again he had to undergo revision. The chemotherapy couldn't be continued. He developed hyponatremia, and he was not responding to antibiotics at that time. And he was unhappy with the treatment again at that time.
Right. So just think about how it must have panned out when you actually, the surgeon told him it's a simple decompression and fusion, and you'll go home in 3 days, and see what it's led to. So don't take anything lightly. I think that's a strong message. Yes, Dr. Pillai, your last rapid fire.
Rapid fire. This is again a 64-year-old man. He presented with severe back pain, night pain, difficulty walking, and he underwent L4 discitis, underwent PLIF, interbody fusion 2 level L4-5 and 5S1 for discitis at another center. Combined back with again collection at the lumbar spine with implants. So I opened up pus coming out again. So I removed the pus, washed and then replaced. I didn't remove the implant at this time. Then he was put on antibiotics. He didn't have any more. And at 5 months and now at 9 months, the implants are retained and he's doing absolutely all right. The infection.
Fantastic, fantastic. So 2 bad
So
cases of
these are
infection.
two different cases. Yeah, the first one was there was pathology behind, where the primary surgeon didn't address the primary pathology and did a wrong method of doing a laminectomy in the presence of a burst fracture there, and the primary pathology was not addressed. But here, the infection settled out with a simple washing and debridement, and he was all right at the end of 9 months without implant removal. But in the initial case, we had to remove all the implants.
Lovely. Thank you, Dr. Pillai. Fantastic cases for our learning. Shailesh, can you take over and give us take-home messages?
Yeah. I think very interesting
Dr.
session,
Pillai, can you
and
stop
everyone
sharing your
has
screen?
significantly contributed a plethora of cases, right from Dr. Dave sir, Dr. Rege, Dr. Suresh Pillai, Dr. Vignesh, and Alok Sharan, of course, was different from what we normally see. And Anku's starter was one of the most amazing start for this revision spine seminar. I would just like to sum up with all that we should be very few points which we all should take it in mind when there is a revision spine. We should always do a thorough clinical examination. That is the key. A lot of things which will come across, like sometimes there can be neuropathy, we may miss some herpetic eruptions. These are the things we should not miss clinically. MRI may say something, X-ray may say something. So this is one thing I would like to talk about is examination is most important. Second is array of investigations. We should never miss a good X-ray, dynamic X-ray, blood investigations are paramount so that we don't miss any infection in these cases. And if need be, a good MRI along with gadolinium contrast MRI, which will be a very useful tool to differentiate a recurrent or residual disc or scar tissue or a disc or any infective focus. We normally do not need PET scan, but in very rare situations, we may need to do PET scan in lumbar spine divisions. CT scan is definitely of a big role in situations which are unanswered at times, and there can be issues like what Dr. Vignesh has pointed out with calcified disc. After that, one thing which we did not show today was dural tear, because it's a complete different spectrum and we go in a lot of different discussions, but that's also one very, very important point when we talk about the revision spine surgery. Dural tear and nerve root injury. These are the two things which can contribute a lot in revision. So we have to be very meticulous when we assess our X-rays, MRI, and the patient. This is the important thing. Your technique will definitely help you, whether you do an endoscopic surgery, you do minimally invasive, microscopic surgery, or open surgery. Whichever you are comfortable in, doing a good revision surgery is important. Decompression versus fusion, there are certain important guidelines for when you want to fix whether the patient is having a back pain, as Dr. Bharat Dave has told us, instability, any deformity. In this situation, we have to consider and think about fusing the spine. But in cases where there is a recurrent disc and we can get away with decompressions, probably we can get an answer for these situations. And we have to be always take opinions. If you think you are in doubt, there is a team approach. You can talk to your colleagues, you can talk to your friends who are expert in this revision. Sometimes it can be a nightmare, on table. So there is no problem that you ask for help also in these situations. And ultimately, what is most important is giving the best answer to our patient who is coming to us. And I thank you all for a great spinal revision webinar. Thank you all for a great help. And I would like to thank Abhay for a great moderation along with me. Thank you, all of you. Thank you. Stay safe.
Yeah.
And we'll fight Corona.
So thank you very much from Alembic, sir, for giving us the opportunity to connect with you, to entire faculty. So we would definitely like to, connect with you again in going forward in future also. And it was a very, very good interactive session across. The lot many cases were there, and participant definitely had learned a lot from your opinions, sir.
Yeah, I would like to ask Amol for a vote of thanks.
On behalf of the Pune Association of Spine Surgeons, I would like to thank all the faculty and all the delegates who are listening to this seminar. So good night and stay safe at home. Bye.
Yeah.
Thank you. Thank you. Thank you very much. Thank you.
Bye-bye.
Yes, Ashok.
Ashok sir is there? Or?
I think he is the one who can. There was some little technical hitch for the presentation of Vignesh's second case, I think. But you presented very well, Vignesh.
Thank you, sir. Thank you.
Hello.
Yeah, Ashok, we are done.
Hello,
Thank you,
sir.
Ashok, for thank you, Ashok, for a great help. And Ortho TV was always a big support and backbone for us.
Thank you, sir.
Thank you, thank you, thank you. How much was the thing? How was it? Was attended well?
Yeah, it was attended well. Yeah.
Chalo. But hey, Are, we should not take these guys in, because they created a lot of chaos. ये सब 4-5 लोग था, a lot of noise was coming, double shaky noise. अरे बहुत frustrating है. ये बाकी सब लोग का जरूरत ही नहीं है यार.
But that is what the. Just a minute. Somebody. Just a minute. Can the host stop the streaming, please?
Jayesh?
Can you stop the streaming?
Yeah, just. I think Jayesh.
So the streaming is stopped, sir.
No, no.
So
Up live on YouTube, just stop it.
No, sir. It is not on live on YouTube. We have just saved the recording on cloud. That's the only thing it is showing red.
Okay,
Otherwise,
just make me host, please.
Yes. So I've made you host.